Welcome to the deep dive. Today, we're zeroing in on a seemingly small bone in your foot that plays a surprisingly massive role, the talus.
It really does.
Yeah.
Often overlooked, but absolutely critical.
We've got a fascinating stack of information to explore with, you think of it as your cheat sheet to understanding this crucial piece of your anatomy.
Yeah, we'll be pulling out key insights from a few different sources.
Exactly. We've got a detailed review on talus fractures, a paper laying out the anatomy and like the clinical side of injuries.
And some interesting biomechanics stuff too, right?
Yeah, a study using computer modeling, finite element analysis to see how cartilage damage impacts stability.
And another one looking at how the talus actually sits differently in people with chronic ankle instability compared to those without.
So consider this your guided tour of the talus. We're going to explore its structure, how it functions, the ways it gets injured.
And crucially, what those injuries mean for movement and stability. Our goal is basically to distill the most vital info from these sources.
Give you a really clear picture of this often unsung hero of the foot.
Couldn't have said it better.
Okay, so let's dive right in with the basics. What exactly is the talus, anatomically speaking? What are we looking at?
Well, the talus is a foundational bone in your hindfoot. It's essentially the bridge connecting your lower leg bones, the tibia and fibula, to the rest of your foot.
So it's right there in the ankle joint complex.
Precisely. It's got a unique shape. There's the main body, which has that dome fitting under the tibia for weight bearing.
Uh-huh.
Then there's a neck and a head that connects forward to the navicular bone.
Okay.
You'll also hear about lateral and posterior processes, just bony bits sticking out.
Right.
But here's something really interesting and kind of unusual.
What's that?
Unlike most bones that carry weight, the talus doesn't have any muscles directly attached to it.
Wait, seriously, no muscles. How does it even move then?
Its movement is entirely dictated by the ligaments connecting it to surrounding bones, and the force is transmitted through it from the leg down and the foot up.
Wow, so it's all passive movement based on connections.
Exactly. And speaking of surfaces, a huge percentage, maybe 60 to 70%, is covered in articular cartilage.
That smooth stuff, right? Like on the ends of chicken bones.
Pretty much, yeah. Think of it like a super smooth, low-friction coating. It lets the talus glide against the tibia, fibula, the calcaneus or heel bone below it, and the navicular in front.
So it's all about smooth connections being acted upon by other structures. Functionally, what's its main job?
Structurally, its number one job is load transfer.
Okay.
Every single step you take, the weight coming down your tibia gets channeled right through the talus,
Lynn?
and then it distributes that load out across the rest of your foot. That's absolutely central to how you support your weight and move.
Now, these sources also mention some specific angles, the varus and plantar flexion angles of the talar neck. Why are those angles important?
Ah, yes. Those angles, the varus angle, usually between 10 and 44 degrees, and the plantar flexion angle, maybe 5 to 50 degrees, they basically describe how the neck is oriented relative to the body of the talus.
Like how it's tilted.
Kind of.
Yeah.
Think of it like the alignment of parts in an engine. These subtle angles are crucial for the overall biomechanics of your foot and ankle.
And if they're off?
If those angles are outside the typical range, it can potentially lead to instability or uneven stress distribution through the foot. It throws things off kilter.
One thing that really jumped out at me from the sources is how vulnerable the talus seems with its blood supply. Why is that?
That's a really critical point.
Yeah.
Yeah, the talus gets blood from a network of arteries,
Yeah.
the posterior tibial, anterior tibial, and perforating peroneal arteries mainly.
Okay.
They form this sort of ring and anastomosis around the head and neck, feeding the body from there.
But there's a but, right?
The but is that because so much of the surface is covered by that articular cartilage we mentioned.
The slippery stuff.
Right. There just aren't that many places for blood vessels to actually enter the bone.
Ah, I see. Limited access points.
Exactly. So if that blood supply gets disrupted, maybe by a fracture, especially one that moves the pieces apart,
Uh-oh.
the bone is at a significant risk of something called avascular necrosis, or AVN.
Which is bad news.
Very bad news. It means the bone tissue actually dies because it's starved of blood.
Yikes. Okay, that sounds really concerning. So what kinds of things typically cause these talus injuries?
The sources are pretty clear on this. Most callus fractures result from high-energy trauma.
Like what?
Motor vehicle collisions are number one. Then motorcycle accidents, falls from a significant height, pedestrians getting hit by cars.
Yeah.
That kind of major impact.
Makes sense. The forces involved must be huge.
Immense. They just overwhelm the bone's capacity.
But can that talus also get injured in like lower force situations? It seems like such a robust bone for load bearing.
Interestingly, yes. The research points out that a fair number of talus neck and body injuries can happen in scenarios we'd think of as lower energy.
Such as?
Things like falls from just about 3 feet, so 1 meter, or twisting injuries, like in rock climbing.
Really?
And even surprisingly, just during normal walking sometimes.
Yeah.
It shows that even seemingly minor events can occasionally have pretty significant consequences for the talus.
Okay, let's dig into the specific types of fractures then. Sounds like there are a few ways it can break.
Absolutely. Talar neck fractures are the most common. They make up something like 45 to 50% of all talus fractures.
Half of them, basically.
Pretty much. And these are often classified using the Hawkins system.
Right, the Hawkins classification. You mentioned AVN risk earlier.
Yeah.
Does this relate?
Directly. This classification is super important because it doesn't just describe the fracture pattern, it also gives us a really good idea of the risk of developing that avascular necrosis we talked about.
Okay, walk me through the Hawkins types. What are we looking at?
Sure. It's types I through 5. Type I is non-displaced. The bone fragments are still lined up correctly.
Okay, best case scenario.
Relatively speaking, yes.
Yeah.
The AVN risk here is low, maybe 0 to 13%.
All right, type 2?
Type 2 means the fracture is displaced, and the subtalar joint, that's the joint right below the talus, is dislocated.
Ouch, risk.
Risk jumps up significantly, maybe 20 to 50% chance of AVN.
Okay, getting serious. Type 3.
Type 3 is even worse. Displaced fracture plus dislocations of both the subtalar joint and the main ankle joint, the key bitalar joint.
Double dislocation.
Yeah.
Wow, AVN risk must be high.
Very high. Ranges from 20% all the way up to potentially 100%.
100%, so almost guaranteed bone death in some cases.
In the worst cases, yes. The blood supply disruption is just that severe. Remember those limited entry points for blood vessels?
Yeah.
A displaced fracture, especially one tearing things up around the neck, can easily sever the key arteries supplying the talar body, like the artery of the tarsal canal. That's why the risk skyrockets.
Makes sense. And type 4?
Type 4 adds one more dislocation to type 3. So you have the subtalar and stibiotalar joints dislocated, plus the telonavicular joint, where the talus meets the navicular bone in the midfoot.
So basically, everything's out of place.
Pretty much. And the AVN risk, very, very high, usually cited as 70 to 100%.
Those numbers really drive home how critical that blood supply is. What about other kinds of talus fractures besides the neck?
Well, talar body fractures are less common, maybe 13 to 23%. These often happen from a direct axial load, like landing really hard on your heel.
Compressing it.
Exactly, squashing the talus between the heel bone and the tibia. Talar head fractures are even rarer, 3 to 10%, often seen with major dislocations of the whole talus.
Okay.
And then there are lateral process fractures. These are interesting.
Why is that?
There's a really strong link, something like 88% with snowboarding.
Ah, the snowboarder's fracture. I've heard of that.
That's the one usually happens with a forceful upward bend and inward twist of the ankle, common when catching an edge.
Got it. So a whole range of patterns depending on the injury mechanism. How do doctors usually diagnose these if someone comes in after a fall or accident?
Initial step is typically plain x-rays, radiographs.
Standard procedure.
Right. But it's important to know, standard x-rays only catch about, say, 74% of talar injuries.
So they can miss things.
They definitely can, especially if the fracture isn't displaced much, if the pieces haven't moved far apart.
So what then?
If there's a strong suspicion based on how the injury happened or the patient's symptoms, or if the x-rays are unclear, a CT scan is usually the next move.
Computed tomography.
Yep. CT gives much more detailed cross-sectional images. It can show fracture lines or subtle displacements that were totally invisible on the initial x-rays.
Makes sense. Better detail.
And sometimes specific angled x-ray views of the foot are used too. They can give a better look at the talar neck in particular.
Sounds like a thorough imaging workup is really key then, to not miss anything. What are some of the major complications that can happen after a talus fracture, besides AVM?
Unfortunately, yeah, there are several potential problems. We've hit AVN pretty hard, especially with displaced neck fractures because of that blood supply issue. The Hawkins classification is our best predictor for that.
Right. What else?
Another big one is post-traumatic arthritis.
Arthritis from the injury.
Exactly. Damage to that smooth articular cartilage at the time of the fracture can lead to arthritis developing down the line in the subtalar joint or the main ankle joint. Subtalar arthritis is actually a really common long-term problem after talus fractures.
And given how central the talus is for weight bearing, I imagine healing in the right position is absolutely critical.
Oh, absolutely. Malunion, where the bone heals crooked,
Non-union.
where it just doesn't heal at all.
Yeah.
Both are significant risks. Because the talus connects so many joints and transfers so much weight, even a slight misalignment is poorly tolerated.
Like what kind of misalignment?
A common one is healing with a bit of an inward tilt, what we call varus, through the neck. That can really mess up the foot's mechanics and cause chronic pain. Non-union rates vary, but it's definitely a concern.
Any other complications?
Well, infection is always a risk, especially with open fractures where the skin is broken.
Makes sense.
And then there are rarer things like complex regional pain syndrome, CRPS, which is a nasty chronic pain condition, and blood clots, venous thromboembolic events. Documented, but thankfully less common.
Okay, let's switch gears a bit. Another type of talus injury mentioned in the sources. Osteochondral lesions of the talus, or OLTs, what are those exactly?
Right, OLTs. These are injuries that affect both the articular cartilage, that smooth surface, and the bone directly underneath it, on the talus, usually up on the dome where it meets the tibia.
So like a pothole in the joint surface.
That's a pretty good analogy, yeah. Damage or defects in that crucial weight-bearing surface and the bone supporting it.
And how do these OLTs impact ankle stability? Does the research say much?
It does. This is where that finite element analysis study comes in, the computer modeling.
Right, simulating the ankle.
Yeah, it showed that OLTs can definitely change the ankle's biomechanics. They can affect stability and function. The model let them see how stress distribution changed and how much the talus moved differently when an OLT was present.
Very cool. What did they find about the size of these defects? Does size matter?
It seems to. We kind of knew already that deeper defects, like more than 3 millimeters deep, are bad news for stability. But this study looked more at the surface area, keeping the depth shallow, like 1 millimeter.
Okay, so width and length.
Exactly. And they found that defects smaller than 6 millimeters by 6 millimeters didn't cause significant changes in contact pressure or talus movement during heel strike, that initial impact.
Ah,
But as the defects got bigger, 6 by 6 millimeters or larger, and as the foot moved through mid-stance and into push-off,
the later parts of walking.
right, the effects became much more noticeable. The biggest changes were seen with the largest simulated defect, which was 12 by 12 millimeters.
So there's like a threshold around that 6 by 6 size?
It seems that way. It suggests that around 6 by 6 millimeters might be a sort of tipping point, where the lesion starts to significantly affect ankle stability during weight-bearing activities.
What does that mean clinically?
For treatment, well, it suggests that for smaller OLTs, maybe under that 6 millimeter diameter mark, conservative treatment focused on symptoms might be reasonable first. But for larger ones, the biomechanical disruption might be significant enough that surgery to try and restore that joint surface could be more important for long-term stability and preventing further damage.
Interesting. Size really dictates the potential impact there. Now, let's move to chronic ankle instability, CAI. How does the talus position seem to differ in people with this condition?
Yeah, CAI. That frustrating condition, often after repeated sprains where the ankle just feels like it's going to give way all the time.
A really common problem.
Definitely. And the study using synchronized ultrasound and motion analysis offers some cool insights.
What did they find?
They found that people with CAI had a significantly greater distance between the talus and the lateral malleolus, that bony bump on the outside of the ankle,
Okay.
throughout the stance phase of walking compared to healthy controls.
So more space between those bones while walking?
Exactly.
Yeah.
Which indicates there's some dynamic mechanical instability happening. The joint isn't as tightly controlled during movement.
So in people with CAI, the talus isn't quite sitting right or moving correctly as they walk.
That seems to be the implication, yeah. The study also found the CAI group tended to have less ankle dorsiflexion, less upward bending during the middle and end of stance, and also greater ankle inversion, more inward tilting.
So altered movement patterns overall.
Right. It suggests that even during something as basic as walking, the bones in the ankle of someone with CAI are moving and positioned differently.
And what does that increased distance, that gap between the talus and malleolus, tell us about the ligaments, like the ATFL?
Good question. That increased distance strongly suggests there's more stretching or tensile stress on the anterior talofibular ligament, the ATFL.
The main one people sprain on the outside.
That's the one. It's a key stabilizer, preventing the talus from sliding too far forward and limiting that inward roll. The fact this increased distance is seen during walking suggests the ATFL might be under constant extra strain in people with CAI.
Which could contribute to the instability feeling and maybe make it easier to sprain again?
That's the thinking. Yeah, it might be part of that cycle of recurrent injury.
It's interesting, though, that the study mentioned these differences were seen during movement, but not necessarily when the ankle was just static, resting.
That's a really crucial observation. They noted that static ultrasound measurements, just looking at the ankle in a neutral position, might not show significant differences in that talus malleolus distance.
So just looking at it while someone's sitting still might miss the problem.
Exactly. It really highlights why dynamic assessments, actually looking at how the ankle bones move and interact during weight-bearing activities like walking, are so important to truly understand the mechanical issues contributing to chronic ankle instability. You have to see it in action.
This has been a really thorough look at the talus. Wow. To kind of bring it all together, what are the key things you'd want our listeners to really take away from this deep dive?
Well, first off, I think just appreciating that the talus, while small, is incredibly intricate and absolutely vital for your foot and ankle.
Right.
It's the linchpin for weight transfer and smooth movement.
Right, unsung hero.
Totally. Second, it's definitely vulnerable to injury, often from high-energy trauma. But we learned even lower impact events can cause problems like fractures or cartilage damage.
And those injuries have consequences.
Big time. Fractures, especially displaced ones, carry those serious risks like AVN and post-traumatic arthritis. Getting the diagnosis right and treating it properly is key.
Uh-huh.
We also saw that even seemingly small cartilage defects, those OLTs, can impact ankle stability, particularly when you're putting weight on it, with that 6 by 6 millimeter size maybe being a threshold.
And the CAI connection.
And finally, yeah, in chronic ankle instability, the talus demonstrably behaves differently during movement. The increased spacing suggests underlying mechanical problems are contributing to that feeling of the ankle giving way.
Fascinating stuff. You know, considering this complex anatomy and all these subtle ways injuries can affect the talus and just the whole ankle function, it really makes you think.
Hmm.
How might a deeper understanding of these specific biomechanics, like the talus position in CAI or the impact of OLT size, how might that actually influence how we design rehab programs
Mhm.
or even preventative strategies for ankle injuries?
That's a great point. Are there things we're overlooking?
Yeah, like what overlooked factors might be playing a crucial role in someone's long-term ankle health and stability that we could target better if we understood these talar mechanics even more deeply? Definitely something to mull over.
Absolutely, food for thought.
Thanks so much for walking us through this deep dive into the talus. Really appreciate the insights.
My pleasure. It's a fascinating bone.